All right, Margaret, any luck? All right.
Yeah, that's good.
Okay. Okay, so good afternoon, everyone. I'm Dr. Malcolm Samuel, Chief of Renal Transplant Surgery at Eric Williams Medical Sciences Complex in Trinidad. So I'm just gonna quickly go through our experience, what we've been doing, and a few statistics, and give an idea of some of the challenges that we have faced and what establishing a full-fledged transplant unit will face. Next slide, Margaret. Thanks. So in Trinidad, the first transplant was done locally in 1988. He actually survived 30 years. He was transplanted, he received a kidney from his sister, San Fernando General Hospital, and went back on dialysis in 2019. Subsequent to 1988, there were 36 live donor transplants performed in Trinidad up to 2005, both private and public, but they were only live donors. No deceased donors were done. It was not an organized program, but in the mid-2000s, it was realized that there was a need for it because the number of people on dialysis was increasing exponentially. And at the time, there were some 300 plus people on dialysis in 2005 and increasing. Next. So there was an era in between 1994 and 2006 when a lot of Trinidadians journeyed to India and Pakistan for transplant tourism. And that also motivated the authorities here to have a local unit set up. Next. So the first journey was to India. Next. Second journey was to Pakistan. Next. One of the issues was that the morbidity and mortality was high. A number of patients would go and they shipped out a couple of weeks after, unlike the patient who described, what she underwent in Barbados. Some of these patients were put on a plane a couple of weeks after, shipped back to Trinidad, and then they were found to have all kinds of issues, surgical as well as infectious. So the morbidity and mortality was high. Next. The numbers obviously reflected a demand and query desperation. Next slide. So what do you need to have a sustainable transplant program? So what we realize is that there are four main pillars. First of all, you need to have the laws. Trinidad has a Human Tissue Transplant Act, which governs all organ donation and all removal of tissues from the human body, both for live and for deceased donors. This was done in 2000, and the regulations were adopted in 2004. You need to have financial support. So you need to have a Ministry of Health on board to support the donation and the recipient, the transplant process. You have to establish a mechanism for this to be done, and this was the National Organ Transplant Unit, or NOTU, and we develop a transplant program. So we have a transplant program for kidneys and corneas in Trinidad. And all of those will then lead to a sustainable organ transplant program. Next. We started in 2006 when our first patient was done, received a kidney from his sister, and he is now in his 16th year, as we are now in our 16th year, and he has done very well. It's at Eric Williams, and it was created to perform renal and corneal transplants for Trinidad and Tobago citizens and residents. We perform both live and cadaveric or deceased donor transplants. Next. Our activity is governed by the Human Tissue Transplant Act, which governs the removal of all organs and tissues. And this is very important because for deceased donors, our cadaveric program, you have to have the concept of brain death established as a legal definition of death. So once you can do that, then you have the legal wherewithal or backing to be able to remove organs from somebody who's legally and clinically declared brain dead. That obviously facilitates our deceased donor program, and our legislation also prohibits and has clauses which prohibits organ trading. Next. We first started with our live donor program in January 2006, still functional. Our deceased donor program was launched in April 2007. We have an opt-in scheme, which means that patients have to opt in, or donors and their families have to opt in to the process. We don't have an opt-out system as exists in countries like Spain, now in the UK, and other European, mainly European countries, where you are considered, or where an individual is considered a potential deceased donor unless he otherwise objects. And this gives Spain, for example, the highest rate of deceased donation in the world. Right now, we have about 20 patients on our deceased donor waiting list. Next. We also have established under the Human Tissue Act an ethical committee. It ensures ethical practice, no coercion, no payment, organ training. Donor and recipients understand the donation process. Our members are all independent of NOTO, and no staff members are involved in the deliberations. We have social workers who prepare psychosocial assessments, and they are then seen by this committee. So all pairs who are not first generation genetically related are screened: spouses, uncles, cousins, friends. The only people who are not screened under our legislation at present is children, parents. Next. So our live donor program, we started with our local surgeons. First case, however, problem developed. So we brought in an overseas surgeon, and over the next 2 years, 2 surgeons mentored the program. And since the second half of 2008, all of our cases have been done by a fully local team, except for TLC, who we work with to do pediatric cases. And we have done 2 right kidney donors with a visiting surgeon from Spain. Next. Now, in our deceased donation program, what is important for a deceased donor program is obviously to identify the donor. So what we have done in cooperation with DTI, which is Donation Transplant Institute, which is an organization based in Barcelona, Spain, is that we have trained a number of intensive care doctors who act as transplant procurement managers. And we have 1 station in each major hospital in Trinidad: Port of Spain, San Fernando, Sangre Grande, Eric Williams, and Tobago. So these persons identify a potential deceased donor, somebody who comes in with a head injury, trauma, stroke, and is admitted to the ICU for intensive care. They will say, this person may be a potential donor. So NOTO is alerted so that we can then generate our patients and let them be on standby. However, NOTO is not involved in the process of management, because obviously it will be a conflict of interest. So we are hands off. So the transplant procurement managers, in conjunction with the intensive care unit staff, will manage patients according to standard protocols. Once they realize that the patients are not going to recover, then you do what is called brainstem testing. And our regulations state that 2 separate independent doctors must do brainstem testing 6 hours apart. And once that's done, then that person is legally dead under the definition as exists under our Human Tissue Act. Next. The transplant procurement managers then perform the family approach. Again, NOTO, our staff, we do not get involved in this process because we have to adopt a hands-off process so that there is no question as to any kind of funny thing or any kind of underhand things happening. The coroner is alerted in the event of a police-involved case, which would occur in crimes, gunshot wounds, motor vehicle accidents, assaults, trauma, etc. As I said, we are not involved until the requisite family and coroner permission is obtained. We then proceed to retrieval. We then perform tissue typing and cross-match, which we do in Trinidad at Eric Williams. And this is another key requirement for a deceased donor program. You must be able to have your tissue typing and cross-match done within a 6-hour to 8-hour time period in your country. Fortunately, from the outset of our program, all of our cross-matching was done in Trinidad. It was first done by CAREC, which is now CARFA, but then they transitioned that to Eric Williams. So this has facilitated us doing our live and our deceased donor program. And then we implant in the selected recipients. We normally cross-match 3 to 4, just to make sure that we get the best match. Next. Our collaborations are with Transplant Links, similar to Barbados. They mainly assist us with pediatric transplants, and we performed 10 since 2008. We collaborated with the Donation Transplant Institute from Spain, and they've been supporting us since 2010. And we've had surgeons trained in deceased donor retrieval. We have 3 surgeons, including myself, who are fully trained in deceased donation, deceased organ retrieval. So we are all happy to come and help. Margaret, whenever you're ready to start. Next. This is just our staff, surgeon, transplant nephrologists. We have 3 coordinators. We have 2 recipient coordinators because we are following up 127 patients at present. And we have our donor transplant coordinator who looks after our waiting list and who also manages the workup for our live donors. 2 social workers, our administrative staff, and the team is made up with help from Eric Williams Medical Sciences Complex. Next. So up to this point, we have done 195 transplants, live donor 149, 76%, deceased donor 46. We have had 2 patients who have had 2 second transplants. One was done because she had acute rejection initially, and the other, his graft failed, unfortunately, after 7 years. I think his disease came back, and he had a second graft. So we've had 117 males and 78 females, and predominantly, it seems as if a lot of our renal failure patients are actually males as well in Trinidad. Next. We presently follow up 127 patients. 25 have gone back on dialysis. We've had 43 deaths over the period. Unfortunately, we had 3 COVID-19 deaths among our recipients last year. We actually had 4 patients who tested positive. 1 fortunately recovered, but 3 others did not. We have had 4 MIs in the first 30 days, 3 anastomotic bleedings, and 1 patient died from CMV, which is cytomegalovirus, which is one of the common infectious causes which can cause problems post-transplant because of the immune suppression. Next. This is just a chart showing our activity over the years. Our greatest peak of activity was in 2014 when we actually did 20 transplants in 2014. We did 10 live, 10 deceased donor. Last year in 2020, despite COVID, we were able to do 10 transplants, 6 live donor and 4 deceased donor. Next. This just gives an idea of the type of procedure we did. We started with the open nephrectomy. We're now doing hand-assisted laparoscopic donor nephrectomy, which is standard. And we've done 74, 3 from the visiting TLC team, and 71 I have performed. Next. We have developed our skill level to the point where we are now tackling more difficult cases. So we have done donors who have had 2 renal arteries. We haven't tried 3 yet. We have had 2 donors who have had 2 double ureters. We've done 2 right kidneys, and we've done pediatric cases, which obviously are more technically challenging because of, for the recipient, more so than the donor, because donors tend to be adults, whereas the recipients tend to be smaller. The youngest we have transplanted pediatric was age 9. We have an 11-year-old working up to be done this year. Next. Some complications which happen, we have had to convert due to bleeding, re-exploration. Our morbidity is quite low. We have had 2 incisional hernias, and we have had no deaths. The thing to take home from this slide is that deaths in a live donor program is a disaster. So your donors must not die, no matter what, because you're asking them to go through a major 2 to 3 hour procedure for which there is no necessity for them. Next. So as I said, none of our donors, none of our 147 donors has developed, live donors has developed chronic renal disease. We've had 5 donor pregnancies, and 1 male has developed prostate cancer. We have had, next. 1 in our recipients, we've had 1 acute rejection, 1 primary non-function, 4 delayed graft function. We have had 1 young man who has developed a malignancy. Next. We've had 3 ureteric stenoses. All of them have been treated. Ureteric leaks, which are common, and those have been treated successfully, as well as a lymphocyte. Next. Achievements for our recipients. We had the first female live recipient, female recipient, amongst our 195 patients who delivered a young male in 2019. And I think this is probably the first, and I stand corrected, in the English-speaking Caribbean for a recipient who is on immune suppression to have had a successful pregnancy. 6 of our male recipients have had children post-transplant. We've had many of our younger patients complete school and university, and 2 are actually in medical school at present. 1 in Barbados, 1 in Trinidad. Next. Challenges. What are going to be your challenges? And what has been our challenges? Funding. The transplant budget, the budget for supporting transplantation is 1% of that for dialysis. One of our TPMs did some research, and the budget for dialysis in Trinidad is about 75 million TT dollars. And our budget that we have, that we can spend outside of the cost for salaries, is less than $1 million. So transplant needs to be funded much better, because in the long run, a patient who has had a transplant is cheaper for the government to support than somebody who is on dialysis. Usually after the first 2 years, the costs fall up to 50%. Bureaucracy has caused delays in essential supplies for us, like reagents for tissue typing, and having readily available immune suppression drugs, because all of our patients receive their immune suppression drugs free through the government, through our unit. We need to have an improvement in our lab services. We need to upgrade our facilities so that we can do flow cross-match. We can do antibody identification, because there are patients who patients who have failed, or patients who have had previous sensitizing issues. We need to be able to do antibody identification in their cross matches. We need to be able to do viral titers for post-transplant patients so that we can detect CMV and BK, which are 2 common viral infections which cause issues post-transplant. A transplant-related immunologist will be an asset, and we need a renal pathologist to diagnose our pathology. Next. You also need a transplant IT system, because when you reach the numbers that we reach, we're running out of storage space. You need to mount a comprehensive education program to sensitize your public and attract more potential donors, especially if you're going to start a deceased donor card carrying system. Staff needs to be upgraded, you need to educate, and you need to have succession planning. That last one is just an in-house thing. We are going to be going under the aegis of a regional health authority rather than the Ministry of Health. But I think in Barbados, that would be, you just have one major hospital, so that wouldn't apply to you. But you need full government support and the support of your board. Next. What are we hoping to achieve? Well, we want to reach our 200 this year, and I think we should be able to. We want to get to the point where we're doing 25 to 30 per year. Our best year was 25, our least year was 8. That was a lot of issues. We want to try a paired exchange. This is an exchange where if somebody has a relative who is willing to donate, but they are not compatible, then that person can donate to another person, and then the other person's donor can then apply. Public education, etc., etc. Next. So, as I said, the 4 pillars, as I mentioned, what are the intangibles? Education, institutional support, succession planning. You need continuous monitoring and reevaluation. Next. And you will see on the left your kidney prepared for your donor, and on the right, your kidney transplanted and urine being passed. This is what you want to achieve as a transplant surgeon. And I thank you for your patience.
Yeah, very good, very good. Dr. Samuel, I just want, this is a simple question. Do you think within the Caribbean, amidst the political directorate, that there's any kind of willingness that the Caribbean can become a world-class hub for transplantations, both from a cost-saving point of view and also from a earner of foreign exchange?
Well, I think, first of all, what we have to do is to work together so that we share our expertise. Because right now, we have the longest running and the most optimal functioning at present unit. We have 15 years of experience. Guyana has started, Dr. O'Shea and Dr. Bell and Dr. Joran are at the early stages of the process in Barbados. I have mentored, I've been to Jamaica 5 times to mentor their programs in Montego Bay and Jamaica. So I think the first thing we need to do is to work together. We need to share our expertise, and we need to come together as a region so that you have centers established, because the Eastern Caribbean islands are not going to be able to facilitate transplantation. I know Antigua has a program, but I have no idea what stage or what level it's at. So I think that's the first thing. And then after that, we can then look at whether we can have persons who come to us because the cost savings, because our costs are 50 to 60% less than in the US. If somebody, for instance, from the Caribbean wants to go to the US to have a live donor transplant, they are looking at 150 to 200,000 US dollars off the bat. I know someone who was able to get her name on a deceased donor list in Florida, and she had to pay 100,000 US dollars to list her name on the list. And when she was called, she had to provide another $100,000 before she was even transplanted. she's done well and she's been going. But that's the kind of figure that you are looking at. I think that your question is a good question, but personally, I think we need to deal with our problems first, because we have a lot of problems. There are people, the smaller islands, the OECS countries, they are having increasing incidents of renal failure. And I know Barbados is also on the uptick. Trinidad is on the uptick. We have probably about 1,800 people on dialysis, and people go on dialysis every week in this country. So let us fix ourselves first, and then we can open to earn foreign exchange. But I'll tell you, even if we fix ourselves, we can save money. So that may redound to the benefit of the governments who have to fund their local dialysis programs.
Could I ask a question?
Sure.
In Trinidad, the donor, any costs related to the donor, does the donor have to pay that cost themselves? Because I know insurance companies do not cover the donor.
Well, in our program, which is a government-funded program, there is no cost to the donor.
Okay.
And I'm qualifying that by stating that some of the investigations that they require, like renogram scans to look at their split function and the filtration rate, there are some tests which unfortunately sometimes are not available in the public sector. So patients pay for that. But which, if they have insurance, the insurance, we can find a way of getting the insurance pay for it. But I've done.
The insurance doesn't pay if.
Yeah, I know. They don't pay. So it's often funded by the recipient or the donor themselves if they are a family member. I have done 4 private cases in the private sector here. 2 from Dominica, 1 from St. Vincent, 1 from Barbados. And we had problems, yes, with the insurance companies paying for the donors. But yeah, the insurance companies do not, which I don't understand, because you can't have a transplant without the donor. So
exactly,
makes no sense to me. But
yeah.
that's the situation.
Yeah.
Yeah.
Mrs. Branca, I've reached out to the insurance companies here, okay, and I've also been able to get some case out in India. I have a contact in India, which they do cover the donor for 2 years. So I now have a precedent I can take to the insurance company to show them that, because it doesn't make sense. The only way that you're going to expand that program is if you cover the donor, because he's an integral part of the operation.
But more importantly, too, they don't cover the donor, but if you want to take out certain policies, you have to pay higher than somebody who, if you're a donor.
Yeah.
Like because I'm a donor, I have to pay my certain policies. I have to pay sometimes double what everybody else is paying because I was a donor and because I only have 1 kidney.
Yeah.
It doesn't matter whether I'm healthy or not, and I'm quite healthy, but they don't see it that way.
Wow.
If I may say something, good evening, everyone.
Hi, Mr. President.
Hi, thank you, Tunisia. Good job. Thank you so much, Doctor, for the excellent presentation on transplant. I speak on behalf of the insurance, so I just wanted to interject here very quickly. But I do sympathize with the notion that the insurance companies would not help the donor, and it doesn't make sense. The principle really is that if the donor himself is not sick, because the rationale for the health insurance is for when you get sick. And therefore, the perception is the recipient would get the benefit as long as the recipient has insurance, his or herself. But what do you diagnose the donor with, if you understand? So that's one side. The other one that is a little bit difficult to kind of put over and be some sympathy with you, is once that donor now has lost, yes, the kidney, there's a perception that there's increased risk because of that person's living on one kidney. And that is where medicine would have to convince the insurance companies that the risk is not compromised. And therefore, insurance companies are open to discussion. And I'm sure if the good doctor and others can make the case that the person is as healthy as they were, there's no increased morbidity. I'm sure there are people who are willing to listen, and eventually that will be a thing of the past. So I like what's happening here. The discussion begins. I'm going to ignore what you said, that you find a way around it. I think I heard that.
Yes, you heard it. You heard me correctly.
I think I heard that.
Yeah.
I'm going to pretend I didn't hear that.
I am sorry, but I make no apologies for that.
Yeah, that has caused an increase in healthcare to some unfortunate persons. It has also caused a little bit of friction between medical and insurance interpretation of justice. So, yes, I understand you may want to do that. I can sympathize, but that has a negative impact ultimately. So do it discreetly. Don't tell us if you're doing it. If not, it really doesn't help anybody at all.
Don't worry. I've been doing this for 17 years. So
Okay,
I know my way around. But
Okay,
the question I want to ask you is, as far as you are aware, and as far as I am aware, health insurance in the US covers the donor. Am I correct in stating that?
Not I'm aware of. So if you know of
Okay.
something that we have as an example to follow, then
Okay.
I think we should.
Fine. The second thing is, there has been enough work done on patients who have, because there are people who are born with one kidney, there are people who lose a kidney from trauma, accidents, etc., and who have lived a normal and full life. So there's enough statistical evidence available, and there's enough evidence for your actuaries, who I think are the ones who call the shots. There's enough evidence out there which will show the insurance companies that somebody who is screened, and when you screen a donor, you screen them from the hairs on the top of their head to the soles of their feet. So anything in between, we find it. And these people, once they take care of themselves, as we advise them to, they are no greater risk than somebody with two kidneys. Okay?
That's after the fact. But I think where you want to get to the point is, really donor is actually compensated for given. I understand your point. After the fact, I can live normal, and therefore the evidence is there.
Right.
But one of the questions is, how can we help the donor recover some of the costs? And that's where the question of, what do you diagnose the donor with that will suggest this person had a reason to give a donor? And that would be a question that insurance company.
Yeah, right. That's for another forum.
Yes. Okay.
Tanisha, before you, Gail, could you turn on your camera and say hello to everyone? Thank you, sir. She doesn't. I don't not seeing the audio. All right. Yeah, her audio doesn't seem to be working. So go ahead, Tanisha. Go ahead, Tanisha.
Sorry, just a question for Dr. Samuel, quickly.
Sure.
Hi, Dr. Samuel. Sadie Ann Cisnet here. Transplanted 2 years. I was interested in the statistics you showed with your female recipient who had a live birth.
Yes.
I just want to know how well she was doing, how old she was, what was the kind of parameters for your female patient after she gave birth in terms of her kidney function.
Her kidney function is good. She is doing well, and she was doing well at that time. She's actually now one of our transplant coordinators. So she is a vital member of the team, because her perspective to our recipients is is fantastic. She came to us a year before and told us that this is what she wanted to do, because we advise our post-transplant patients not to attempt to try to get pregnant for the first year. And if you are going to do that, then you come and work with us, because you have to switch from mycophenolate, which is teratogenic to the fetus. So we have to switch you off of mycophenolate, and we use azathioprine, which is safer, and we have to monitor you very closely, and we have to work in conjunction with the obstetrician, but it has to be planned. It should never, ever, 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 ever be ad hoc or accidental. That's the message that I want to transmit, that it must be planned, it must be done in conjunction with your transplant nephrologist and your team looking after you. But she has done well, and we are happy, we are hoping that there are others who will follow suit. For men, it's easier because their sexual function returns and their fertility returns much easier than women. And they don't have the issues of immune suppression.
You heard him? Yeah, he was telling you to turn on the camera.
So I hope that answers your question.
Yes, thank you, Dr. Samuel. I'm kind of in that position right now. So everything that you have said is definitely familiar to me. I just wanted to make sure, the risk to the graft, if it was any more, or once your patient is doing well or has done well since the transplant has done well, no signs of rejection, anything like that. So that would give me a bit of hope as well, a bit more hope, I should say.
Yeah.
If you can, I can link you up with Anne-Marie. If you can just put your email in the chat, I will link you up with Anne-Marie, and you all can, chat, so she can give you her perspective and her experience. But it didn't affect her graft at all.
Okay.
And it shouldn't, once it's done in a planned and appropriate manner.
Yes.
And she also was like you. She had her donor who was her brother. So you're at least a 50%. I don't know what your match was, whether yours was full or whether it was 50, but she had a full match from her brother.
Yeah, Dr. O'Shea can answer that question. But yeah, I thank you. I'll put my email in, and as Dr. Jarawan said, it's a group effort.
Yes, it is. It's not a solo thing.
Hi, Dr. Samuel. I have a question for you. My name is Abiola Batiste. I'm a nurse at the John Hayes Memorial Foundation. Yeah, hi.
How are you?
Doc, I wanted to find out regarding for our females who are transplanted and would like to have children, right? Mm-hmm. Does that affect the lifespan, their lifespan?
No.
In terms of, let's say they want to have 1, 2, 3, does it affect it at all, or they are free once they, coordinate it? That's a question. Is the lifespan affected at all?
Well, technically, no, it shouldn't. I wouldn't recommend somebody have 2 and 3 and 4. We can certainly work with 1, probably 2. I would not recommend, and this is just empirical. I don't think that there's any hard evidence that multiple pregnancies, but obviously will have a deleterious effect. But obviously, if they're unplanned, then I think if somebody wants to have a baby, then they need to plan it, and they probably should consider no more than 2 well spaced out.
Okay, I have one more question, please, regarding the COVID vaccination. Has there been any research? I think they're doing that now in Barbados, but has there been any research done as to what could be the effect of taking the vaccine, any of the vaccines on transplant patients. I know we have been given, here in Barbados, we've been given advice that as a
You should
transplant,
take it.
you should not take it right now, should not.
Well, I am not. We
So-
have had 4 patients who have had it. We have had 3 who have died. My position is that, and I think our position in the unit is that, given the risk, because there is more and more data now coming out, both from the US and the UK, which shows that some transplant patients have up to a 40% fatality rate once you get COVID. It's a vaccine which is almost 300 million doses have been given worldwide, and I'm not convinced with some of the hoopla that's out there. My reading, and certainly my colleague, we both agree that when it becomes available, we will be recommending that all of our patients take it, because the risk of death and dying from a transplant recipient getting COVID, as we have seen, even though our numbers are small, is quite high. That's my take on it. And that's our policy in Trinidad.
Very good. Very excellent. Dr. Summers, I'm sure we're going to have lots more questions for you. So we hope we can have your email address. We will not bombard you because you're a busy person.
Oh, I'm good. I have time.
We have a lot to learn from you.
Manchester United won this evening, so I'm happy. So I can stay with you all for as long as you want.
Okay. All right. So we will, if you can have your email address, we would, I probably have, you would.
Okay.
Any questions in the future?
Sure.
So we hand back over to you, Tanisha.
Hi. All right. So thank you so much for that presentation. That was very informative. And I see we had a very lively discussion, lots of questions. Even the president came in to share his views regarding how the insurance companies tend to handle these situations. And like he said, hopefully going forward, we'll have some more progress in that department on the insurance agents and our insurance industries end. Like I was saying earlier when Mr. Hurdle was talking, I did some research and I did see, like Dr. Samuel was saying, that in the States and stuff, that they have a little bit more support from the insurance and even through the Social Security and stuff like that. So that is something for us to consider on a Caribbean level, how we could give you guys more aid and support. Next person is Dr. Merle Clark, who's a nephrologist from St. Lucia. Is she here?
Dr. Clark, you're there? I didn't see her.
It's not there.
Okay, so we move on to Dr. Garrett. Dr. Dean Garrett.
Dean Garrett. So
Yeah.
Dr. Dean Garrett, and they're talking about vaccines and COVID-19. And I think that person is from the USA. Okay, so they're up next. Did you confirm that Dr. Garrett is here? Yeah, you saw him. Okay,
Yeah,
sure.
yeah.
So he's up next. So we'll listen